Welcome to this session. We are going to have a very nice lecture, I suppose, by Dr. Guillermo Ruiz-Irastorza, who is a consulting physician in internal medicine and head of the autoimmune research unit and professor of medicine at Hospital Universitario Cruces, University of the Basque Country, Spain. He was a research fellow at the LUPUS research unit at St. Thomas Hospital in London. He's a member of a SLIC and coordinates the first Spanish national lupus inception cohort study called RELES. So Dr. Ruiz-Irastorza is going to give us a talk on antimalarials revisit. Welcome, Dr. Ruiz-Irastorza.
Okay, thanks very much for all that. Well, thanks very much for the invitation, and also thanks very much for the topic I have to cover, because it's one of my favorite ones, as well as one of the Tela's favorite ones. And we are going to talk about a very old drug, which is probably discovering some new aspects over the last years. As you all know, antimalarials are actually, and that is why they were invented for, very effective microbial killers. And the main mechanism of action is actually very, very simple. They just rise a little bit the pH of the lysosome and make the intercellular life very difficult for external agents. What is surprising is that antimalarials are not only antimalarials. I mean, they work obviously against Plasmodium, but there is a very wide range of actions against many bacteria and also many viruses. So I will come back to this later on, but this is a very important point. But obviously, apart from that, antimalarials are immunomodulatory agents. And the mechanism of action, the main mechanism of action is actually the same. By raising the lysosomal pH, they interfere with the action of innate immunity mediated by toll-like receptors. So the trick here is that they interfere the processing of low-affinity antigens, such as the autoantigens. However, they do not interfere the processing of high-affinity antigens, which are most of the bacterial antigens. So they are immunomodulatory, but they are not immunosuppressive drugs. So they help you control the autoimmunity without conferring an immunosuppressant state, which is very, very important. And probably this is not the only effect. And as you can see in a recent review by Dan Wallace, there are many other effects. Some immunologically mediated and some others not, which can explain why the antimalarials are so useful in treating patients with lupus. Really, the story of antimalarials is long, it's an old story, and they began to be used almost by chance, like many other things in medicine. And the story starts when the American and British soldiers fighting in the Pacific Front in the Second World War were treated massively with mepacrine for the prevention of malaria. And some smart guy observed that patients with rheumatological conditions receiving antimalarials were actually improving from their symptoms. From there, they started to empirically use and expanded the use to first to rheumatoid and then to lupus. And then have been used in lupus, as you all know, for many years. But the classical indication for antimalarials in SLE has always been a very low-grade indication. This is a recent, as far as I know, the most recent ULA recommendations, consensus recommendations for the management of SLE. And as you see, the role these recommendations give to antimalarials is pretty poor. It's just they can be considered or used in people with SLE without major organ manifestations. So it's used for very mild lupus. You have skin rashes, you have joint pains, okay, you can give hydroxychloroquine. Otherwise, you can use the real strong drugs. Well, the question is that enough? Is the only real indication for antimalarials are joint pains and skin rashes, or there is something more? Well, I try to convince you that there's much more, actually. And we have really old studies showing that there's something more. And this is the famous Canadian hydroxychloroquine withdrawal study in which patients with lupus on remission were randomized to continue hydroxychloroquine or withdraw. And as you see, the group in which hydroxychloroquine was suspended had a much more higher rates of flare, not only of global flares, but also of severe flares, which is a very important point. And well, some confirmation of this study has been recently published by the group of Nathalie Costedot in Paris, showing that there is a relationship between the blood levels of hydroxychloroquine, which can be measured, and the activity of the disease. They also ran a randomized control trial trying to demonstrate that if you improve the blood levels, you are going to have a better controlled disease, but they couldn't find this point. If you want to discuss, I think Natalie is in the audience, you can discuss with her. So, activity is obviously a very important part of the story, but it's not the only and not even the most important part of the story. We see lupus activity when patients are with joint pains or are with proteinuria, but behind activity is damage. And damage, as you know, is probably the major prognostic factor for survival and quality of life in lupus. So our practice should be directed not to only to control activity, but especially to prevent damage. And a work by the group of Chela Alarcón already demonstrated that patients with lupus treated with antimalarials do accrue less damage than those who do not receive. And these results have been reproduced by other groups, and recently in the SLEEK group, in the SLEEK cohort, in an analysis that is being about damage, the results are almost the same. And damage in general, but also damage at renal level. We're not talking only about joints and about skin. We're talking about serious organs like the kidney. So antimalarials can help prevent permanent, irreversible damage at the level of the kidney. This is a very, very important question. And obviously, if you use this drug, it can help you to reduce the dose of steroids. And this is a major point because, as you know, steroids is a big source of irreversible damage. And not only damage, but also impact in the life of lupus patients. So this could be an additional good effect of antimalarials. But not all the effects of antimalarials are anti-inflammatory. We know also for years that they have an antithrombotic effect mediated by several mechanisms, including inactivation of platelets. And we saw in our cohort that actually the patients treated with antimalarials do develop less thrombosis than those never treated. And the group of Maria Tectonidou in Greece also saw the same, but they divided the group in patients with and without antiphospholipid antibodies, and they showed that antimalarials works in both groups. It helps prevent thrombosis in lupus patients without APL, but also in lupus patients with antiphospholipid antibodies, which is a major advantage also in these patients. We, probably you know, we performed a systematic review of the effects of antimalarials in SLE, which was published in 2010. It was really tough work, and especially because most of the studies are obviously low-quality studies, but we were able to assemble some evidence and to give strong recommendations in certain areas of SLE. And as I said, we saw that there are at least moderate evidence of prevention of thrombosis, of prevention of damage, and low anecdotal but probably clinically meaningful evidence of other funny things, like, for instance, the prevention of cancer, which is, oh, I'm going to take it, but really this has not been reproduced in other groups, but it has really medical sense, because antimalarials can stabilize DNA and have been used as adjuvant in some therapeutic, chemotherapeutic regimes. So it has medical studies, but this is obviously the level of evidence is low. There's also a possible effect on the protection from bone loss, also possible effect from protection from lipid disturbance and metabolic syndrome. But after this review was published, there have been some works pointing to very interesting additional effects. First, prevention against miscarriage in APS, probably through the protection of the annexin A5 layer, which protects the placenta from thrombosis. The group of RAN has shown that the use of antimalarials can protect this shield from the attack of antiphospholipid antibodies. Second, protection against congenital heart block. You all know that there is no preventive treatment for this condition. 2 trials of immunoglobulins have been published with no results. And funny enough, retrospective studies, first in patients with lupus and then in patients with and without lupus, have shown that there is a big reduction of congenital heart block in women with a previous episode, a previous baby with heart block, in which the expected rate would be 20%. They have shown that in the group of women who took antimalarials, this rate was down to 7%. So it seems that also in this subgroup could be of use. And for instance, we are recommending antimalarials, hydroxychloroquine, to all women with anti-RO antibodies who are coming to our pregnancy clinic. And lastly, this study of our group showing that antimalarials can prevent infections, which is obviously logical to think, because I have shown before, there's a wide range of antimicrobial effects of antimalarials. First, you can decrease the dose of steroids by using hydroxychloroquine, but also there's an intrinsic antimicrobial effect which can help prevent infections in patients with lupus, which, as you know, is one of the major causes of morbidity and mortality. So there are many effects, but the most important thing we can say about that is that antimalarials improve the prognosis, improve the survival in patients with SLE. And this has been seen in 3 different cohorts, from the ethnical and geographical point of view, in our cohort in the Basque Country, in the cohort of Alarcón in the States, and also in the GLADEL cohort here in Latin America. So it is very important. The studies were very similar. They were all controlled for confounding by indication. And the only thing is the Latin American study added the information that the prolonged use of hydroxychloroquine is more protective. So there is no other drug in lupus which can show results like this. Obviously, these are not clinical trials, but obviously you cannot think about a clinical trial lasting for 15 years. So these are well-done cohort observational studies, and they practically copy the results from one to another. So we think that there is enough evidence to say that antimalarial use has a prognostic implication in patients with SLE. Okay, at what cost? Well, this is all this stuff is what appears in the leaflet of the drug in Spain. Obviously, if a patient comes out to read all this, they got in panic and say, well, I'll never take this pill. But obviously, most of these side effects are really mild, are infrequent. When we did a systematic review, we found that there are several things that can happen. There are reports on myopathy, cardiopathy, some weak data on ototoxicity, but I have to say, in my practice, the side effect which appears more frequently is not severe, but can be disturbing, is itching, is pruritus. Okay? I have had to reduce the dose of hydroxychloroquine in several patients, and usually only by reducing the dose, the effect just disappears. But there's one effect you are all thinking of, it is eye toxicity. And it's a typical question of patients. Doctor, this drug you are giving me is getting me blind. Obviously, the answer is no. Eye toxicity, serious eye toxicity with hydroxychloroquine is very, very rare. It's not that rare with chloroquine, which is no longer used in most parts of the world, and with hydroxychloroquine is really very rare. And what we know is that it's more than rare, exceptional, in patients who have not taken more than 1 kilo, 1,000 grams as cumulative dose. This is at 200 milligrams a day, it is 14 days taking hydroxychloroquine. And even after that, really the actual frequency of eye toxicity is very low. It's also true that we are using, up to now, techniques to detect eye toxicity which only allow us to detect irreversible eye toxicity. And there are now recommendations of the American College of Ophthalmology aiming for more sensitive techniques that allow us to detect more precocious eye involvement. The problem with this is that you can detect very precocious, and then you have to decide whether to continue the drug, which is effective, just to protect something which nobody knows where it's going to be. But it makes sense to widen the range of ophthalmological examinations using more sensitive techniques. We have done this in our court. We don't have still the results, but all I can say now is that the ophthalmologist didn't recommend stopping the drug in any of our more than 200 patients analyzed. So it looks good, but probably it won't change a lot the frequency of eye toxicity with this drug. And also, this is a very important advantage. It is safe during pregnancy. You don't have to stop this drug in pregnancy. And this is, you must not stop this drug in pregnancy because it's safe for the fetus, but especially because if you stop that, the mother will flare, and this will be bad for the mother as well as for the fetus. So still there are some countries in the world where hydroxychloroquine is not allowed during pregnancy, but there are no data at all published and in the clinical experience of many people using this drug pointing to a toxic effect to the fetus. And what is some problems with hydroxychloroquine, you can also have other things. First, you have to remember that this is a cheap drug, and this is available worldwide. In a period of very expensive drugs for lupus, we have now a drug which works and that is easily affordable for everybody. And as I was saying, if you have problems with hydroxychloroquine, you can also use the cousin. Mepacrine, which was actually synthesized before, is probably similar, although the studies with mepacrine are really few. But probably we can assume that has most of the beneficial side effects of hydroxychloroquine. The good thing is that mepacrine has no eye toxicity. So you have to withdraw hydroxychloroquine because of eye toxicity. You can use safely mepacrine. Problems. Mepacrine, we don't know whether it can be used in pregnancy because there is no information, so usually we withdraw. And second problem, it's not serious but could be important, is that it stains your skin in yellow. So you can actually look like Miss Simpson after some months of using the drug, but it is not universal for all patients, and it's really a minor side effect, which can be also overcome with reducing the drug. So we can say that antimalarials are very old drugs, very well-known drugs, for which there are new indications and new recommendations in SLE. In the review by Dan Wallace, they suggest using hydroxychloroquine universally in people with lupus, using chloroquine only for short periods of time due to its high toxicity, but in people refractory because it is more potent, and adding mepacrine together with hydroxychloroquine with potent side effects, or substituting for hydroxychloroquine in patients with eye problems. My own recipe would be that it should be the baseline treatment for any patient with lupus without contraindications. Obviously, it is even more indicated in patients with antiphospholipid antibodies, that you should not withdraw the drug because the lupus is in long-term remission, because you carry the risk of very severe flare, and we have seen that in patients who withdraw because they wanted and they had renal flares. But you don't either withdraw the drug in patients with more severe forms. Just add on other treatments, but remain with hydroxychloroquine as the baseline therapy for your patients. Don't withdraw during pregnancy. Be relatively safe, sure, of no toxicity until the dose of 1,000 grams have been reached, although we perform yearly eye controls in our patients, and probably use more sensitive techniques and take the decision of reducing the dose or even withdrawing and changing to mepacrin in cases in which toxicity seems to be an issue. I think the core of the story is that probably lupus is not a disease, and we cannot probably talk about a treatment for lupus. But for sure, glucocorticoids and immunosuppressive drugs, as far as we know today, are more treatment for manifestations of lupus. Okay, you use corticoids, or you use methotrexate for joint problems, and you use cyclo for nephritis, and once this manifestation is over, the drug can be many times withdrawn. Antimalarials are different. Antimalarials, and especially oxychloroquine, are the treatment for lupus. It's the base treatment for the disease, and as far as we know today, there is no other better drug than this to treat lupus as the baseline. After that, say, okay, this is so fantastic, it's good, it's safe, so everybody is taking antimalarials. The answer is no. Really, when you look in the different cohorts, in the best cases, 70% of patients are taking antimalarials. For instance, the second one is the SLIC cohort, the last one is the Lumina cohort of Graciela. And even in those cases, between 25 and 30% of patients do not take antimalarials. And what we see is that the tendency is not to increase over the time, because some patients are put in the beginning, but then it is withdrawn, some are added, but then there are losses. So it is not yet universal use. And my final message for this talk and for all of you is that given the efficacy, the long-term effects, and the very good safety profile, please don't forget using this drug in lupus patients. Thanks a lot.
The session is going to be open for discussion. I will kindly ask you all to say your name and your country of origin before making your questions. Eloisa.
Eloisa Pons from Brazil. Thank you for your talk, a very nice talk. I would like you to comment on what's your recipe for those taking more than 1 kilo for screening eye toxicity?
The question is where to screen people for eye toxicity.
What's your recipe for screening eye toxicity? In those taking more than 1 kilo, we are having more and more of these patients.
Okay, I think it's the same. Actually, we are not following the recommendations of the American college, because they say before 5 years you do nothing.
Right.
And we are not brave enough to do that. So we keep checking people once a year. And if the ophthalmologist, and I think this is the most important part of the story, is the ophthalmologist's opinion, if they think they should be checked more frequently, we do that. The point is probably we need to use more sensitive techniques, because if you already see a bull eye maculopathy, there's nothing to do. This patient is going to be irreversible damage in the eye. So I think the information about the kilo, I think, is more to get the patient relaxed than to relax yourself in terms of the control. I think yearly controls are okay, and in selected patients, after this dose has been reached, maybe 6 months controls could be indicated.
Perhaps you want to emphasize also that the medication should be given according to the ideal body weight and not to the real weight, and that's important, particularly in countries like Europe and North America, where people tend to be overweight and obese.
Yeah, but in the study by Marmor and the rest, they found that it is actually the cumulative dose of hydroxychloroquine which is the predictor of eye toxicity, rather than being up to the 6.5 milligram per kilo per day. So it seems to be a question rather on the long term and the cumulative dose. And there is another point, and this is our ophthalmologists tell us, that some patients with eye problems taking hydroxychloroquine have eye problems not because of hydroxychloroquine, but because they have a genetic predisposition to have eye problems. Obviously, if they develop a maculopathy of other origin, you should not continue the drug. But probably it's not the guilt of hydroxychloroquine itself.
Hi, I'm from Argentina. I want to know your experience or your message to the nephrologist. For patients in end-stage renal disease who are in 0 of SLEDAI, and sometimes he didn't come back with the rheumatologist and stopped the antimalarials.
Okay, this is a very good point. Well, our recommendation in our patients is continue to take hydroxychloroquine. Obviously, you have to adjust the dose. We empirically give much lower doses, for instance, 100 milligrams 3 times a week. But this is empirical. But using the HCQ blood levels, you can adjust for that. But the message is not to interrupt that, because even though the end-stage renal disease is somewhat immunosuppressive, there are patients who can flare. So I think it's and also has another long-term effects such as atherosclerotic and thrombotic things. So I think should be continued in patients with in dialysis.
Thanks.
Rohini Handa, New Delhi. One of the practical problems is the skin hyperpigmentation, which many women find distressing. Rather than the eye, they give it up just because they find the skin hyperpigmentation quite distressing. Your comments on that?
Yeah, we have some problems with hyperpigmentation in the skin. Usually, by reducing the dose, it is not longer a problem. And again, it can be very much disturbing to the patient, but they should choose. What do you prefer? Having a drug which can keep your very bad disease under remission, or having a whiter skin? But usually by reducing the dose, you overcome this problem.
We're going to have one more question.
Guillermo Munder from London. Nice presentation. We know the maximum dose why we shouldn't exceed. We don't know the minimum dose which keep the patient in remission. Patients are taking, some of them 400, others taking 200. And as you know, in London, sometimes we use 200 3 times a week, and it works. So why we don't design a trial to see the minimum dose keep you in remission going for many years? As our patient, they look the prospect, read the prospect, say, I'm going to go blind if I take it for a long time. So we need to identify the minimal dose keep you in remission, and I think it's easy trial to do.
Yeah, that is a good idea. And also the availability of the blood levels of HCQ could help. We don't know. We try on patients who are on long-term remission. We try to decrease the dose, and some of them are with 100 milligrams 2-3 times per week, and they are doing well. But obviously, this is not scientific, so it's just empirical.